que ça a permis de savoir que nos différents systèmes de santé ne sont pas performants. Il a fallu construire en urgence des structures pour pouvoir canaliser tout ce flot de patients. La communication que va nous présenter le docteur Dominique Vervoort va porter sur l'impact de la COVID-19 sur la chirurgie thoracique et cardiovasculaire. Le docteur Vervoort est chirurgien thoracique et cardiovasculaire, spécialiste de la chirurgie cardiaque pédiatrique. De notre congrès, et il va nous parler de son expérience de la chirurgie cardiovasculaire et la COVID. Dr. Vervoort, you can start your presentation.
Great. Thank you so much for the kind introduction, and thank you to Professor Ngate and the Society, the association, to invite me to speak about access to cardiac surgery around the world, and specifically as to how it relates to the recent COVID pandemic. Next slide, please. So these are my disclosures, mostly all non-financial, but I do want to acknowledge that some of the organizations I work with are discussed in this presentation. And also I am from a high-income country and was trained in high-income countries. And so my perspective is one less so from a frontline experience. And so I'm very much appreciative of all the experiences that you've shared over the past 2 days. Next slide, please. And I want to start off with a very grim number, and that is that 6 billion people, over 2/3 of the world's population, lacks access to cardiac surgical care. Next slide. Now, a big reason for that is the discrepancy in priorities in global health. When we look at global health, we see a big emphasis on, for example, malaria, TB, HIV/AIDS, etc., which get about 50% of all funds related to global health. And as a result of that, there's an enormous research focus on these 3 conditions. Now, when we position that against, for example, rheumatic heart disease, which affects 40 million people worldwide, we see that rheumatic heart disease gets almost 0% funding, and research is very, very minimal every year. Next slide, please. And so now we've recently obviously had the COVID-19 pandemic, which is still ongoing, but at least the acute phase is done. But we've seen that in terms of research, there was, again, a disproportionate amount of research, partially because it affected the entire world, but also partially because the resources were there, the know-how was there, but there was simply a prioritization of COVID relative to other aspects. Next slide, please. So what I want to talk about today is 3 aspects, is partially related to global surgery to kind of frame what access to surgical care generally looks like and why more and more countries, the WHO, the United Nations, and so forth, are focusing on addressing global surgery. Then want to focus on cardiac surgery specifically and related to the pandemic, and then closing with a few slides on how the future can look like in terms of access to care. Next slide, please. One more. So global surgery is a very recent phenomenon, and I see that the font has declined a bit. But in 1980, at the time, the boss of the WHO, the Director General, Dr. Halfdan Mahler, he was the first to talk about surgery in a global health context and for the WHO. Now, not much happened, even though that was the first time that he spoke about it. And when we fast forward 3 decades later, next slide, please. There was a very influential editorial that was published by Dr. Paul Farmer, who unfortunately recently passed away, but is very well known for his global health work, True Partners in Health, as well as Dr. Jim Kim, who ended up becoming the president of the World Bank. And at the time in 2008, they were working together as infectious disease specialists at Harvard Medical School. Now, these were 2 non-surgeons looking at surgical care. And when they were asked why they actually cared about surgery, their answer was simple. If we focus on infectious diseases, we treat patients, prevent infectious diseases, and a patient goes out on the street next day, gets hit by a car, doesn't have access to trauma care, all of those investments have been So it was a great focus to address the cross-cutting nature, the health systems aspect of global health work and of all the work that we're trying to address, to not just focus on infectious diseases or on surgery, but really trying to integrate it. So in 2015, these three documents came out. At the left, you have a document by the World Bank looking at cost-effective interventions in global health for the first time addressing surgery. In the middle, we had the Lancet Commission on Global Surgery, which was the first time academically that we really understood what does access to surgery look like globally. Right was a document by the WHO and signed by all 194 ministries of health working with the WHO, stating, we as ministries of health, we care about surgery, we care about... Perfect. I'll try and speak a bit more slowly. So on the far right, this was the first time politically that the WHO and ministries of health said, we need to care about surgery, we need to care about anesthesia, otherwise health coverage around the world will not improve. Next slide, please. And so next slide, please. The Lancet Commission on Global Surgery, which is the central document here, tried to quantify what access to surgery looks like around the world. And so they estimated that about 5 billion people, so 3/4 of the world's population, does not have access to surgery, obstetrics, or anesthesia care. Now, that 5 billion number is big, but as a result of that, about 1/3 of all conditions that are there globally are due to conditions that require surgical care. And about 18 million people die every year from conditions that require surgery. Now that number, 18 million people, is over 5 times as much as people dying from HIV, TB, and malaria combined every year. Next slide, please. So the same that I just mentioned. Next slide, please. And when we look at the disease burden on the one hand, which is the left, and when you look right, which is the percentage of global health funding that is allocated to different conditions, we see that there's a discrepancy. The burden for surgical care is large, the investment in surgical care is very minimal. Next slide, please. And so globally, about 5 billion people lack access to surgical care, and you can see here in darker red are the places where more and more people lack access to surgical care. And unfortunately, this is affecting low and middle income countries in particular. Next slide, please. Now, luckily, in the recent years, more and more countries, more and more governments are actually addressing this or taking this into consideration. And you see here policy plans, national surgical obstetric and anesthesia plans, which are abbreviated as NSOPs, and they're being developed by a variety of countries, as you can see, mostly in Africa, to address surgery from a policy perspective. And a variety of countries have launched their plans in recent months. Other countries also beyond Africa have been doing so. And I've had the fortune to work with the first non-African country in Pakistan to develop a plan for Pakistan, for the government, to address surgical care in the country as well. Next slide, please. And so much is happening at the local level by countries committing to it, but also internationally with the WHO, the United Nations, the Global Surgery Foundation, actually putting themselves behind access to surgical care. And so arguably, surgery is no longer the neglect, but much is still to do. Next slide, please. And so we focus then on cardiac surgery because that's why we're all here. And cardiac surgery is much more of a recent field. Next slide, please. Especially then within the global surgery field. And cardiac surgery from a global cardiac surgery perspective was defined for the first time in 2018 as an area of practice, so the clinical aspect, but also research, so study, advocacy, and policy related to access to surgical care. Next slide, please. And so it's important to consider that because while we're talking about cardiac surgery, it's important what happens within the operating room, but most people can't actually reach the operating room. And so accessibility in terms of distance, accessibility in terms of resources, accessibility in terms of quality of care, and accessibility and access in terms of affordability, so the costs are crucially important. And when we consider all those four components, 6 billion people still lack access to cardiac surgery. Next slide, please. And so here you see different data points for each of these different pillars. More recent data has shown that there's only one center per 13 million people on average in Sub-Saharan Africa. There's one per 0.6 million in high-income countries. The capacity of cardiac surgeons per million population is almost 200 times income countries compared to low-income countries. The quality, however, is actually very good. And we've seen presentations yesterday and this morning of the experiences of several of the centers that are participating here, but also centers that have published from outside of this room that have shown that some centers are actually doing equally well, if not better at times, than several centers in high-income countries, showing that the skills are there, but the resources are just needed to actually be able to access care and to move further. And then lastly, in terms of affordability, costs are still very much prohibitive if the government or NGOs don't help subsidize it. Although countries such as, for example, India, Vietnam, etc., have now been performing cardiac surgery at less than $2,000 per patient. So costs can really be reduced to a very low amount and need to obviously be subsidized further by governments and NGOs. Next slide, please. And so here you see graphically kind of the data that I showed in terms of cardiac surgeons and where they're distributed and the amount of surgeons per million population. These are data from 2017, 2018, so not fully accurate, but they still represent the current state. And you see on the left, you see adult cardiac surgeons. On the right, you see pediatric cardiac surgeons, and you see that there's a big discrepancy. So the lighter the country, the lighter the color here, the fewer surgeons there are per million population. Now, when we look at centers, and you see that here, and it's perhaps a difficult figure to understand, but just to kind of illustrate that in 1995, it was estimated that there's 0.7 centers per million population around the world. 28 years later, we just 0.73, so only 0.03 centers per million population more, which is almost no improvement. And the reason for that is not that there is no improvement, because there's almost 2,000 more centers around the world. However, the population size is just growing so fast that centers cannot meet the demand. Next slide, please. And so NGOs are doing tremendous work. We've heard from a variety of groups here, Chaîne de l'Espoir, CardioStart International, and so forth, that are doing a lot of work and are working with all of you to not just focus on the clinical aspect, but also capacity building. But we're seeing that in total, they're year, which is only a very small amount of numbers that are actually needed for cardiac surgery around the world. So while it is good, it's actually not enough in terms of what is needed, and a continued move needs to happen towards local care. Next slide, please. And so, as I mentioned, so a lot of these NGOs have eventually resulted in local centers and are continuing to be supported by them, which is critical. And also many more and more countries are recognizing the fact that it doesn't necessarily make sense to send our patients abroad. We have to find ways to treat them locally. Now, this was an example of the experience of Ghana, where they realized, okay, early on, we were sending a lot of patients abroad for cardiac surgery. They were being sent to India, to China, to the US, and so forth for about $50,000 per patient, including surgery, including travel, and so forth. And in the National Cardiac Thoracic Center in Accra, in Ghana itself, they were treating them at the time at about $10,000 per patient. So they could save about $40,000 per patient every time that they would need to treat a patient, which amounts to a huge amount of money if we look at 10, 100,000 patients over time. Now, all of that money gets invested into the local health system, creating more jobs, providing training, letting patients be treated closer to home with an environment that they know and people and cultures that they're familiar with. Again, illustrating that there's not just an economic, but also a moral reason to kind of invest in local care. Next slide, please. Also, from a cost effectiveness perspective, this is difficult to understand perhaps, but it is important for policymakers, is that they want to know, if I invest money, how much benefit am I going to get in terms of health gains? And when we look at global health interventions, which you see a variety of global health interventions like HIV/AIDS antiretroviral therapy, breastfeeding promotion, seatbelt laws, etc., that are very cost effective in terms of reducing the disease burden. Actually, pediatric cardiac surgery, while it is very costly, while it is very expensive, is actually more cost effective than these already cost effective interventions. Again, illustrating that while it is costly, it is also very cost effective. And that is something that governments need to understand. Now, unfortunately, funding is not following through, and this is a figure that shows neglected tropical diseases, neglected infectious diseases, including rheumatic heart disease. The further we go on the right, the bigger the disease burden, the further we go up, the more funding it gets. You can see rheumatic heart disease at the bottom, big burden, low funding. Other neglected diseases, lower burden, higher funding. And so again, a big discrepancy between funding and needs. Next slide, please. And we see that in policy documents as well. I want to focus on the right because that's more surgical. But these are surgical policy plans by countries that have developed their plans where governments said, okay, we need to address surgery. Unfortunately, only one country so far, which is Zambia, had actually incorporated cardiac surgery as part of those policy documents. And this goes to show that governments are starting to pay attention to surgery, which is good, which means that surgeons are advocating well, but cardiac surgeons are not yet at the table. And so it's, again, another example why cardiac surgeons need to connect better with governments and need to ensure that if these policy plans are developed, cardiac surgery is a part of that. Next slide, please. We see that internationally as well. Unfortunately, at the WHO in 2018, a resolution was released on rheumatic fever and rheumatic heart disease, which was great. It was a very important step in addressing rheumatic heart disease. However, it did not talk about surgical care. The background document, the background research recognized that rheumatic heart disease is surgical. You need to address surgery. But when the governments eventually saw the resolution, saw the final document, it did not mention surgery. And so again, an unfortunate loss, so to say, where surgery is not mentioned. Next slide, please. And so it is unfortunate, not just from a policy perspective, that it isn't just mentioned. It's not just from a purely clinical perspective, but there's tremendous economic benefits for governments, just simply because of the fact many patients die early, whether it's due to congenital, rheumatic, ischemic heart disease. And all of these individuals could, in turn, contribute to socioeconomic growth. If they're no longer around because they die or because they're unable to work from their conditions, there is a loss of socioeconomic growth. And so it was estimated that the African Union, just by addressing rheumatic heart disease through surgery, could benefit almost $3 billion US dollars by 2030 if they actually invested in surgical care. Next slide, please. And so you might ask, okay, well, other than perhaps cardiac surgeons not necessarily being connected with the government, what are reasons for this gap? Why are policymakers not addressing global cardiac surgery? Next slide, please. And when we look at rheumatic heart disease, this was a study where researchers had interviewed a variety of policymakers from around the world, and they asked them, rheumatic heart disease, the burden is large, you know that, but why do you not care about it? Why do governments not address this? The answer was actually very simple, is that there was not enough data, especially local data. There was disagreements between different groups as to how we have to address rheumatic heart disease. Do we only prevent it? Do we also think about surgery? Is it infectious disease? Is it a non-communicable disease? There was a lot of disagreement. And because of that, governments decided, okay, if the people who are treating it don't know, why should we know? And so they focus on other aspects. And so that is very similar with us in cardiac surgery, that the policymakers are generally not cardiac surgeons. And if cardiac surgeons are not providing the data or communicating with them, it's hard for them to actually understand what is actually necessary. Next slide, please. And so this brings me to the pandemic, because all of these data are pre-pandemic, but obviously the pandemic affected this further. Next slide, please. Early in the pandemic, about 30 million procedures, and this is not just cardiac surgery, that is any kind of surgical procedure. In the first 3 months of the pandemic, almost 30 million surgeries were canceled around the world, meaning almost no hospital was doing surgery, and a lot of people were waiting for surgery. And in the months that followed, that kind of continued as well, meaning that currently there's still an enormous backlog around the world. Next slide, please. And so this affects different components of access to care, because accessibility became more difficult. There were lockdowns, there were travel restrictions, there were fewer teams that were traveling to countries, there were fewer patients sent abroad for care, fewer patients internally in the country that could travel to a center. Fewer centers were operating because some centers had to actually shift their resources to managing COVID care. ICU beds were required for COVID, surgeons, anesthesiologists, intensive care specialists had to actually treat COVID and so forth. And so there was reduced access. Quality of care was complicated in patients with COVID-19. There have been studies that have looked at patients with COVID who had cardiac surgery, and they had a high risk in terms of complications. And then the affordability also means that fewer people were able to work, reducing income, but also fewer NGOs, fewer visiting teams coming and subsidizing surgeries, leading to fewer people able to get surgery as well. Next slide, please. Now, in the next slide, please. In the months that followed during the pandemic, we better understood as to what the actual gaps were around the world, how countries are managing it, what are some relevant aspects to cardiac surgery and to the health system at large. And when we look at intensive care capacity, and if you can go on to the next slide, you see a map of the distribution of centers, where we actually see that the amount of ICU beds that are available per population, which were used not just for cardiac surgery, but also critical care, was actually, again, just like surgeons, very unevenly distributed around the world. Next slide, please. You can see here. And so here, darker means lower density. And when we look at the distribution, apart from 3 countries, unfortunately, Africa had a very low number of ICU beds, which predictably probably will have addressed COVID-19 early in the pandemic. Next slide, please. And so many centers were struggling. Many programs around the world were kind of grappling with, do we continue to treat patients or not? How do we address the fact that borders are closed? How can we manage training and so forth? Next slide, please. And the World Society for Pediatric and Congenital Heart Surgery did a survey amongst congenital centers around the world and found that most centers actually either closed or reduced their volume by more than half. And most centers estimated that it would take them 2 or more years to actually, or up to 2 years to actually resolve their volumes, meaning a great backlog and a lot of time to increase their volumes again. Next slide. And so a variety of centers, next slide, please. A variety of centers around the world, especially then also in Africa, have published their experiences with regards to COVID as to how it relates to fewer surgeries, fewer patients being treated, fewer patients being admitted, fewer patients being screened, and amongst those that are actually being treated, that they also had challenges with regards to follow-up and so forth, which remains an issue up until today. Next slide, please. So there have been a couple of examples, and if you, perhaps you can move on 2 or 3 slides by now. Could we move on to the next slide? So there have been experiences shared online, and this is a webinar that was recorded and was also an experience by Nigeria that was shared as well by Dr. Falassi, as well as by centers in Sudan and Tanzania, if you would like to hear from those experiences as well. Next slide, please. And as I mentioned, a couple of experiences have been published, and the next few slides are sequentially South Africa. There was an experience as well from Nigeria with regards to congenital care. And then lastly, in Egypt, as to how they're now addressing the backlog and trying to reopen and learn from the pandemic. Next slide, please. 2 more, if you can go on. Thank you. And so this is kind of a more recent experience from one of the centers in Egypt, trying to see, okay, what can we learn from the pandemic? What can we learn from the fact that there was less training? How can we maintain telemedicine and telehealth for follow-up, for diagnosis, for consultations, and so forth? Because the challenges that were faced during the pandemic, reduced training, reduced follow-up, et cetera, challenges that were existing before and challenges that will continue to persist after the pandemic kind of resolves. And so, so it's a great article kind of discussing that, but it kind of shows that we're moving towards a new paradigm. Next slide, please. And virtual education is a very big component of that. We are here with a hybrid meeting. We are sitting in the room. but some of the speakers are joining us online. And it's something that during the pandemic was quite well adapted, with more and more meetings turning virtually, providing opportunities for people around the world to participate. Next slide, please. One more. Now, unfortunately, as I kind of transition to the last part of my talk, is that conferences have kind of shifted to pre-pandemic reality, and few cardiac surgery conferences currently provide virtual components. The conferences that exist are mostly in person. The cost that it takes to participate in a conference is high, and unfortunately, most conferences don't actually have discounts to participate, providing enormous accessibility barriers. So this was a study where we analyzed all of the conferences globally to try and push the societies to recognize you need to include discounts, you need to include virtual components so more people can participate, and you're not only benefiting the privileged. Next slide, please. One more. And so this kind of transitions us to the future, because while all of this is a stark reality as to what the world currently looks like, we have to move to a future where access to care has improved. Now, this is a study that is coming out shortly, but where we try to look at what the Lancet did for global surgery, trying to study not just access to care for surgical care, but also try and propose targets for governments to address this, and trying to adapt this for cardiac surgery by 2040, which is an optimistic goal and will be difficult to attain. But without goals, countries are actually never moving towards a specific point. And so next slide, please. And so encouragingly, a lot has happened in the 5 years since academically global cardiac surgery was introduced. Next slide, please. Societies are doing more and more with regards to global cardiac surgery, not just the African Association, which is doing tremendous work here, but around the world, a lot of societies are doing work in their respective regions and collaborating to address access to cardiac surgery. This is an effort between several of the societies globally in North America, in Europe, and in Asia, working together with the World Heart Federation to tackle rheumatic heart disease. They're currently supporting a center in Mozambique, the Maputo Heart Center, and King Faisal Hospital in Rwanda to improve their volumes and to increase their capacity. And this is a model where societies could continue to support in other countries as well. Next slide, please. Other groups related to trainees in global cardiac surgery are more and more interested. And here you can see the Global Cardiac Surgery Initiative, which unites medical students, residents, fellows interested in global cardiac surgery, doing research, policy, advocacy work related to cardiac surgery in a global scheme. Next slide, please. From a patient family perspective, the Global Alliance for Rheumatic and Congenital Hearts, or Global ARCH on the left, unites patient family organizations around the world. And these are organizations run by patients and by their families to say, we as patients, we have an effect on our quality of life, we have barriers to care, and we want to be heard as well. And the solutions that you come up with need to come from us, because ultimately the work that we do is not for us, but is for our patients and their families. And so Global Arch unites organizations around the world, and half of them are in low and middle income countries. And if you can see on the map, you see that there's a variety of the organizations as well in Sub-Saharan Africa, showing that here as well, there's many patient family groups that need to be engaged. On the right, you see the Global Surgery Foundation, and that is an organization in Geneva, in Switzerland, that works together with the other organizations that are there, such as the WHO, such as the United Nations, and so forth, to push policymakers to better incorporate surgical care in their policies, but also to engage the private sector to get more invested into surgical ecosystems around the world, specifically then in low and middle income countries. Now, the Global Surgery Foundation has recently launched these two platforms. One is the Search Hub, which is an open access, completely free platform for surgical education. And this is an opportunity for you to share your resources, but also for you to learn from resources from other groups to engage in surgical capacity building. Now, on the right, the Search Fund was recently released in May, which is the very first global fund for surgical care, and tries to mimic what the Global Fund has done for HIV/AIDS, TB, and malaria, but then related to global surgery. And so all of this relates to the fact that we have to care about policy. We have to care about diplomacy. Dr. Martin had shared surgical diplomacy in his talk, and Professor Ngate just mentioned as well that we as surgeons, we also have to recognize that we have to speak to governments, that we have to convey our experiences to them, but also let them know what they can do to help us. And the surgeon advocate is basically this principle is how can we get better at engaging with policymakers so that they actually listen to us? Next slide, please. Part of that dialogue is also research, obviously. Professor Ngate encouraged you to kind of write up your experiences, and that is something that is important. Unfortunately, there are still financial barriers sometimes to publishing in journals, and some platforms like CTSNet, which I believe we'll hear about later, now has an open access platform for you to read, but also publish global cardiac surgery research. And more groups, such as, for example, the NIH on the right, are now trying to support people around the world to do global cardiac surgery research. Next slide, please. Recently, we had an expert group from providers around the world, mostly focused on tertiary care in this aspect then, where the NIH and the National Heart and Blood and Lung Institute engaged us to try and think about what are now the priorities for rheumatic heart disease. And while this was focused on rheumatic heart disease, in a tertiary care perspective, this relates to congenital heart disease, ischemic heart disease, aortic surgery, and so forth, because the challenges are all similar. Next slide, please. And so we came up with a couple of priorities to address, and this might be a bit small on the slides, but the paper is openly accessible online, so you can read it for free. But we tried to up with different priorities in these different components to tackle the burden of rheumatic heart disease. Next slide, please. And so before I conclude, this relates not just to rheumatic heart disease, again, relates to pediatric and congenital heart disease across the different domains of the health system, not just in the operating room, but everywhere from preoperative diagnostics and community-based screening to long-term follow-up, to quality of life, to financial affordability, to data and QI and capacity building, as Dr. Muvando has mentioned, should all be addressed. And all of these are components of a health system that all work together. And all of these issues require us to participate across this continuum and work with others and engage others so that they are also aware of the challenges. Next slide, please. And I want to close with this, with a positive note, and I'm hoping that kind of the experiences from around the world have shared what the gaps are, but also what can be done, but encouragingly also what is continuing, ongoing. And I think the conference that happened last month in Abu Dhabi, the very first World Congress in Rheumatic Heart Disease, was a great example where people from more than 50 countries were participating, most of them from low and middle income countries, sharing their experiences with research and care for patients with rheumatic heart disease was a big win, but also because the boss of the WHO, the Director General, Dr. Tedros, which you can see on the right, gave an address to the World Congress saying, okay, we care about rheumatic heart disease and cardiac care is important as part of the work of the WHO, as part of the work of ministries of health. Obviously, we're here at the African Association meeting, and this is a similar example where, especially from a Francophone African perspective, but also collectively as Sub-Saharan African centers, tremendous work is being done by sharing the experiences and creating opportunities to work together through the African University, through the journal, through the association, and that is something that should be encouraged and is an impetus for future growth as well. So next slide, please. So with that, thank you again for the opportunity to present, and I'm happy to answer any questions.